Good morning, friends. Sorry for the little delay. Today we are continuing our grade series. As Reba mentioned last week, grade was an approach to summarizing evidence for the purpose of making guidelines. Last week, Reba beautifully summarized what was grade and the first part of grade. There are 7 parts, and today she's going to take the grade document 3 of the 3 documents, but it's the second part of our series. So I'll hand over to Reba.
Thank you, sir. Good afternoon. For today's short course in clinical epidemiology, we'll be looking at understanding core grade approach. We'll be looking at the part 2 of it. So last week, we looked at the overview of the core grade. We saw how we could apply core grade in systematic reviews and how we could also apply it for guideline development. For systematic reviews, we saw how to formulate PICO. We learned about how to identify important outcomes, how to synthesize evidence using the different methods of meta-analysis. And we also saw how we use grade for categorizing the certainty of evidence. And we saw in the guideline development process how finally you use it to formulate recommendations, whether you'll give strong recommendations or weak recommendations. And we also saw the 5 domains which can rate down the certainty of evidence. And we covered imprecision last week. This week, we'll be concentrating on this particular domain called inconsistency. So the first and the second paper was covered last week. Today, we'll be looking at the third paper, which is assessing inconsistency. So my talk is in these 4 domains. First of all, would be to choose the right measure of effect when assessing inconsistency. The second one would be the approach to planning for inconsistency. The third part would be the criteria for judging serious inconsistency. And the fourth part would be subgroup effects based on a priori hypothesis. So what is inconsistency? So inconsistency is basically unexplained variability across different studies. You can see in the picture that each of the studies has different effects. Some studies showing no benefit, some studies shows a very good benefit, some study shows a mild difference. Heterogeneity is basically the statistical test which you use to consider inconsistency. We also saw the measures of effect. We saw the 2 types of measures. We looked at the binary outcomes. We also looked at the continuous outcomes. So binary outcomes are any outcome where you give a yes or a no question. So this usually it's the answer to whether you have mortality, whether you're developing any adverse effect. And we also saw how binary outcomes have 2 types. It's either relative effect or an absolute effect. Relative effect includes relative risk, odds ratio, and hazard ratio, whereas the examples of absolute effect would be absolute risk difference as well as the number needed to treat. On the other hand, continuous outcomes, these are numerical variables which fall within a range. And they're typically measured as absolute effects. For example, the number of days. So could be the duration of illness, the hospital length of stay, maybe the functional status, the quality of life. And you actually measure the difference between 2 groups by using the mean difference or the standardized mean difference. We also saw how you have 2 different people where you give a particular intervention and you have the relative effects are similar in both the groups. That means the intervention reduced the mortality by 50%. However, the absolute effect was different in each of the groups. For one person, the absolute effect was around 1%. For the other gentleman, it was about 20% improvement. That was because both of them had different baseline risks. And we also saw that the effect which is most important to the patient is not the relative effect, but actually the absolute effect. So today, I'd like to ask you a question. If you want to assess inconsistency in a meta-analysis, if you were the review author or you were doing the RCT, how would you actually put up your effect? Would you use the relative effect to tell your results, or would you use the absolute effect to tell your results? Okay, so how many of you want to project your result as using the absolute effect? Or how many of you want to use the relative effects? Okay, we see most show of hands for relative effect. So that's right. So let's explain. If you look at this particular picture, you're seeing 3 different populations. This population is a higher risk. You can see the control is in the blue and the control is in the blue and the yellow bar is for the treatment arm. The baseline risk in this control group itself is 30%. And after giving the intervention, it came down to 20%. So we see the absolute risk difference was 10%. But if you put it as a relative effect, that is the relative risk, there was a decrease by 0.67. In this population, your event rate came down from 10% to 6.7%. Your risk difference was 3.3%, but your relative risk remains at 0.67. And in the last scenario, where you have a very low risk population, your final risk difference is only 1%, but your relative risk is 0.67. So what do you understand from this? You understand that amongst all the three population, the relative effect was relatively constant, but the absolute effect changed based on the baseline characteristics. So why we prefer relative effect is, when you're looking at a study, you actually want the results to be consistent. Then only you can pool the study results and it will increase the confidence in that result. If you use absolute effects, for example, the risk difference or the number needed to treat, it will definitely be different in all the different studies. That is why we choose relative effects. If you find any inconsistency in the relative effect, then you should actually probe and see why is there a difference. Okay, so when you assess for inconsistency in meta-analysis, for binomial outcomes, we always use relative effects. But what about continuous outcomes? Continuous outcomes don't have any relative effects. You only have an absolute effect. That means a mean difference. So for continuous outcomes, you use absolute effect. Okay, so now we finished the first part. That is choosing the right measure of effect when assessing inconsistency. Now let's move on to the planning for inconsistency. Now look at this picture. You see that all the study results are quite different. This study shows no difference. This one shows a good reduction in your outcome. This one is actually on the other end. So why is there inconsistency among different studies? So one of the most common causes is a random error. It is just by chance that those results are different. The other reason is there is a variability in the PICO element of each of the individual studies. Maybe this study was done in an older population. This study was done in a younger population. Maybe the place where you did the studies were different settings. So patient characteristics like age, the baseline severity of illness, the socioeconomic status, comorbidities can actually affect your patient characteristics. Your intervention might be different. Maybe the dose of the antibiotics that you use are probably different. Maybe the classes of antibiotics that you used was different. And the duration of administration also plays a role in your overall effect. And maybe the way you do the outcome assessment. Did you take different definitions? Were there different measurement methods? Was there a varying duration of follow-up? So all these cause variability in your PICO elements. So should we design a broad or a narrow PICO? Is it okay to have a broad PICO? What do you think? Do you want your PICO for your systematic analysis? Do you want it to be very specific? Or do you want it to be more broad and across various settings? Okay, how many of you for narrow? Okay, we have one person for narrow. For broad, we have 3 people. Okay, so the merits I'll tell you. If you have a very narrow PICO, you actually decrease the heterogeneity among the different studies. But if you have a broad PICO, you actually enhance the generalizability and will improve your precision because you have a bigger sample size. And if you have taken a broad PICO and all the effects of all your studies are similar, that means you can apply that result confidently to a variety of populations and a large clinical context. But on the other hand, if your effects are varying across the different studies in your broad PICO, it actually gives you an opportunity to see why is there a difference among the various studies. It allows you to explore the inconsistency source. Now, when you prepare for inconsistency when formatting PICO, it's very important that you think ahead and plan ahead. There is no point in you finishing the meta-analysis, looking at the results, and then realizing, oh no, there is some inconsistency. Before you face inconsistency, you should actually think ahead and plan ahead when you're formulating the PICO. That's very important. So this is the core grades advice. So what they tell you is, before you start the study, you have to prepare for the possibility of encountering large inconsistency. So you have to make an a priori hypothesis that will explain an inconsistency. Then you do the study, look at your results. And if you find the results are inconsistent, you must check whether the hypothesis you planned prior to the study, is it explaining your inconsistency? If it doesn't explain your inconsistency, then you rate down the certainty of evidence. So this was an example I had shown last time, how typically guideline members, they actually specify a small number of relative subgroup effects prior to their PICO. So we saw how the COVID-19 guidelines, when they were formulating guidelines for non-severe COVID-19, they had defined some subgroups. They felt patients who had a larger baseline risk of developing the COVID-19, for example, immunosuppressed patients, patients with chronic disease, unvaccinated people, would actually benefit from this intervention. So they had pre-specified this before they had gone ahead with the study. So this is how we should also do. Now, when you're actually considering the effect of a subgroup analysis, you will have three scenarios. One is you think the subgroup that you have chosen, they might affect your overall effect. So then you just admit that you don't know because you really don't know. Sometimes you might be very sure that there is no difference in the different subgroups. Then you just be confident about it. The third is you're very sure that there is a difference among the subgroups and that will affect your result. Then you have to, it's up to you to actually prove that there is a difference. So in core grade, they have given a table. So the first scenario is previous research shows no evidence that effects differ across the subgroups. So what does that mean when you construct the PICO? You basically combine all the subgroups and don't produce a subgroup hypothesis. So for example, when they were developing the COVID-19 guidelines, they felt that the interventions would be same among men and women. So they didn't have to put two different subgroups saying guidelines for men, guidelines for women. They clubbed it and put guidelines for the adult population. Suppose your research suggests that effects differ across patients or intervention subgroup. That means you already know that there is some difference. Then what you should do is when you construct your PICO, you make a narrow PICO or you formulate two different PICOs and you analyze your evidence for each of the PICO statements. For example, when someone was formulating guidelines for transfusions, they realized that the biology for children is different from adults. So the recommendations for children is very different from the recommendations that they told for adults. Now, third subgroup is previous research shows some difference, but you're not very sure. It's very uncertain if there is actually a difference. Then what you do is you go ahead with an overall subgroup, like you don't initially combine all the subgroups, but then you must also specify in your protocol what subgroups you're thinking of and what is the direction of hypothesis. And once you get the effect, you actually test that hypothesis. So for example, when you're looking at whether giving early ART therapy or a delayed ART therapy for patients with HIV as well as TB, what subgroup do you think will actually make a difference in this? A factor which could actually make a difference whether you give early ART or late ART. One is your CD4 counts. So what they hypothesized was patients with a very low CD4 count, if they give early ART, they thought that those patients will respond adversely. So if you feel that there is no difference, you be confident and and you combine the subgroup, don't formulate a hypothesis. If you feel there may be a difference, you admit you don't know, combine all the subgroups, but provide and test a hypothesis. If you feel there is a difference, you have to prove it. You test both the subgroups individually. So when you do this a priori hypothesis, it's very important that you generate a very small number of well-chosen hypotheses. There is no point in generating a large number because you have to then adjust for multiplicity. And the hypothesis that you generate should be based on previous evidence, like an RCT or a systematic review and thorough understanding of biology. So the ideal number of hypotheses is actually less than 4. And if you're unable to predict the direction of subgroup analysis, then just choose a scenario 1. Don't tell the subgroups. And core grade actually discourages us from using post hoc exploration. That is, once you get the result and then you're looking for the cause for inconsistency. So now we've covered the approach to planning for inconsistency. Now let's look at the criteria for judging serious inconsistency. So there are two types. You either have the visual criteria or you have the statistical criteria. So visual criteria, there are three methods. One is you look at the point estimates of individual studies. The second is you look at the overlap of the confidence intervals of the individual studies. And third is you look at the point estimates in relation to your hypothesis, either the null hypothesis or the MID. Let's look at the top study. Do you think the study is inconsistent or consistent? What were your reasons for saying it's consistent? So we look at the point estimates. They're all similar, all 0.73, 0.74, 0.76, 0.71. The second thing we used was the confidence interval. We saw all of them are overlapping. And the third was, we looked at the relation of all these results to your threshold of certainty testing. They're all on one side of the null hypothesis. So we would say that this is a consistent study. But if you look at the study given below, we find that the point estimates are actually differing. Two studies are showing benefit, two studies are showing no benefit. And you can see that the confidence intervals are also not overlapping among the 4 studies. And in relation to the null threshold, 2 are falling on this side and 2 are falling on that side. So this is an inconsistent study. Now, what do you think about this study? Is this consistent or inconsistent? Okay. So let's look at point estimates. Before that, what we must decide is we have to choose what threshold are you using. If you use the null hypothesis, you find that all the studies actually fall towards one side of the null hypothesis. If you go by the MID, which we had explained last time, and you take a threshold of -10, you actually find that 5 studies are falling on the other side of MID, and 12 studies are falling on, 8 studies are falling on this side of the MID. So if you take the null hypothesis, then you wouldn't really rate it down for inconsistency, because the point estimates might be a little bit variability is there, but overall the confidence intervals are roughly overlapping and they're all falling on one side of the threshold. But if you take the MID as your threshold, then you will rate it down for inconsistency.
The important thing is this is a continuous outcome. This is not the previous slide was yes, no.
Yes, no, it's a continuous outcome. Okay, let's look at this particular exercise. Would you rate this down for inconsistency or not? How many of you will rate it down for inconsistency? Okay, we see 3 people rating it down for inconsistency. Why? Okay. So the most important thing is to actually look at the confidence interval overlap. So here you find that all the 4 studies, all the confidence intervals are overlapping. They might fall on either side of the null, but what do they essentially say? Each of the studies saying that actually there is no effect. If you look at individual studies, the first study, 0.89 is your point estimate, but your confidence interval is 0.41 to 1.94. The study is saying that there is no effect. The second study is also saying there is no effect. Third study is also saying no effect. Fourth study is also saying no effect. Understood? So all studies are saying basically the same thing. All the confidence intervals are overlapping. So the important thing to notice is direction of the effect alone is not a criteria for inconsistency. But here there is a caveat. If you notice, all the studies are actually very small. So if the studies are small, automatically the confidence interval will become large. So that's one thing to keep in mind when you're actually interpreting the results. So I wouldn't rate this down for inconsistency. Sorry? So, but if you look at the other statistical things like I-square also, it's also 0. So we don't really rate this down because we also look at the visual criteria. We also take a look at the statistical criteria.
Consistency, we won't write it down, but we must tell the reader that optimum information size or
OIS. You will rate it down for
imprecision.
imprecision.
That will say that the amount of data is less. So even though
So this is another example. This is also to show that over here, you will not rate it down for inconsistency. Because here, all your point estimates are on the same side. All the confidence intervals are overlapping. This is also to show that you will not rate it down for inconsistency, even though you have one study falling on this side of the hypothesis. Overall, all the studies are not showing any benefit, and the confidence intervals are overlapping. So now let's move on to the other criteria called the statistical criteria. If you look at the bottom of your forest plots, you will come across all these various numbers, tau square, I square. What are all these? These are all measures of statistical heterogeneity. So co-grade actually advises us they actually tell us to look at the I-square statistics. But before we come to I-square statistics, I'll just like to briefly explain the basics. So the most common statistic test that we use is Cochrane's Q test. So this is a traditional test for testing heterogeneity. It basically tells you, is there heterogeneity or not? It's using it's based on the chi-square distribution. So if your Q score is very large, it means that there is a larger variation across the studies. So here you have 2 hypotheses. The null hypothesis states that all the studies, the effects are same and the variations are simply caused by chance. Your alternate hypothesis is the variations are not caused by chance. There is actually some heterogeneity. So we're using the Q test to actually disprove the null hypothesis. And it's important that in the Q test that the p-value is not your traditional 0.05. The p-value for Q test is actually 0.1. Why? Because in meta-analysis, mostly we always take few number of studies and the sample size is actually less. So it has a very low power to actually pick up a true heterogeneity. But on the other hand, if you have a large number of studies, your Q score will actually over pick up heterogeneity. So I'll tell you an example of how to do this. So look at this particular picture. Here you're having totally 7 studies. And you're having 2 interventions. You either give corticosteroids or you don't give corticosteroids. And you're looking at whether this study has heterogeneity or not. Do you think this study has any heterogeneity? No. So if you look at this, the Q score is actually 1.51. So next to the Q, you see a number 6. What is this number? This number is basically the degree of freedom. How do you calculate the degree of freedom? You look at the number of columns, which are 2 columns. You look at the number of rows. The formula is columns minus 1 into row minus 1. So for this particular study, you have 2 columns. So 2 minus 1 is 1. And you have 7 rows. 7 rows minus 1 is 6. So 1 into 6 is how much? 6. So the degree of freedom is 6. And you have a table. It's called the chi-square distribution table. So if you're assuming an alpha error of 0.05, you look at the chi-square for that particular alpha error. The degree of freedom is 6. So here your chi-square is actually 12.592. Okay, but the study's Q is how much? 1.51, which is much less than the expected chi-square. So there is no heterogeneity. And you also have a confidence interval, which is more than 0.1. Now look at this study. In the next below study, you have 12 degrees of freedom. That means the study had 13. This meta-analysis looked at 13 studies. What is the Q score here? 114. And the p-value is 0.00. So this is a significant heterogeneity. If you want to look at the table, for 12 degrees of freedom, if you look at the chi-square for 0.05, it's 21. Your Q is much, much more than 21. So that means the study has heterogeneity. So this is the example of how to use the Cochrane's Q test. Now, previously, our focus was on is there statistical heterogeneity or not. But many people argue saying that every study will definitely have heterogeneity. It's just that your Q test might not pick up that heterogeneity because all the studies in your meta-analysis, they have different PICOs, they have different methodologies. So there is heterogeneity, but you're not able to pick up the heterogeneity. So now people are moved off from giving importance to is there statistical heterogeneity to see how much does the heterogeneity really affect your meta-analysis. So that's where your I-square comes into use. So what is I-square? It's the percentage of the variability in the effect estimate that is due to heterogeneity rather than sampling error. So what this tells is, I found this is the most easier for me to understand. So if you look at a pie, the whole pie is basically the variability, the overall variability that you're getting. The slice is basically heterogeneity. That means out of the whole variability, which is due to chance, how much of that slice of that pie is actually because of heterogeneity? The size of the pie is basically your I-square. Okay, if your I-square is less, that means 0%, that means you don't have a slice at all. Your entire variability is because of chance and not due to heterogeneity. On the other hand, if your I-square is 100, that means the entire variability, the entire pie is because of heterogeneity and not due to true chance. But you should understand there are some limitations to this I-square. Suppose your included studies all have narrow confidence interval, then they will not overlap and your I-square will become misleadingly large. The second problem is, we look at this study. If all your point estimates are falling on one side of the threshold, but the confidence intervals are not overlapping, your I-square will automatically become very high, like 94.5, even though there is no inconsistency. So that's one thing to keep in mind. And third thing is, small studies will have wide overlapping confidence intervals, so your I-square will intrinsically become small. On the other hand, large studies have low sampling error and I-square will become very high. So you can see that I-square actually depends very much on your precision, that is your confidence interval. Now I just want to talk about tau square. So where does tau square come into use? So when you're doing meta-analysis, you have two models. You either have a fixed effect model or a random effects model. So what is fixed effect model? Here the researchers are thinking that if you do the study, all the studies are looking at one particular effect, which is the true effect. That's why it's called fixed effect model, not effects. That means they think there's only one true effect. If you do the study everywhere, you should be getting only one effect. And you see that each study has variations. For example, study 1, their result was here, but the true effect is here. Study 2's real effect was there, but the overall mean true effect is in the center. Study 3's result was here, which is very different from your true effect. So here what happens is, large studies are more likely to be true as compared to small studies. That is why fixed effect gives more importance to large studies. But what does random effects model think? What they think is there is no true effect. The true effect lies in one range of true effects. That is why it's given in a Bell distribution. This is an arbitrarily chosen value. That means if you do the study in different parts of the universe, you will definitely get different results. And those results need not be false. So it gives you the opportunity to take into heterogeneity into account. So you find that each study varies from the mean effect as well as among the studies. So the variation between one study to the other study, it's actually called tau square. So you found that Cochrane's Q actually depends on your number of studies as well as your precision. Your I square does not depend on the number of studies, but it depends heavily on precision. But a tau square, it neither depends on the number of studies nor the precision, but there's very limited data on how to interpret it. If you're interested, there is something called prediction intervals, which is actually found in the Cochrane's handbook, where you can read it up. So we have covered how to the criteria for judging series inconsistency. Now let's move on to the last part, which is subgroup effects based on priori hypothesis. Now, what has I square given you? I square has given you heterogeneity, but did it tell you from where the heterogeneity came from? It didn't. That is why you need to have a subgroup analysis to find what is the source of the heterogeneity. So if you look at the co-grades flow chart, what they say is there any important difference in point estimate? Basically, it's asking, is there any inconsistency? If there's no inconsistency, don't write it down. If there is inconsistency, you look at whether all the majority of the studies are on one side of the threshold. If it is, do not write it down. But if you find that there is a significant proportion on either sides of the threshold, then you must look for the hypothesis and test it. If your hypothesis has explained the inconsistency, then don't write it down. If your hypothesis has not explained the inconsistency, then you must evaluate for each subgroup separately. So it's easy to explain this by looking at the analogy of mangoes. Suppose someone has given you a box of mangoes from the market, and you take one particular mango and it tastes really sweet. You take another mango, doesn't taste so sweet. So there is some variability in the sweetness of the mango. So you can think, why is there some variability in the sweetness of mangoes? Did half the mangoes come from a coastal region, or did the other half of mangoes come from dry region? Are the coastal mangoes tasting more sweeter than the dry region mangoes? So this is one thing. One way you can actually divide the mangoes. You put them into two main baskets and you compare them. The other way to compare these mangoes are, what variety of mangoes are these? Is this a Malgova mango? Is it a Banganapalli mango? Is it an Imam Pasand mango? And you put them based on those three baskets. Here, what you can find is some baskets have more mangoes, some baskets have less mangoes. And you can do a subgroup analysis and see whether the variety of mangoes, which is actually explaining your heterogeneity. So the problems is, you can have false positives due to multiple comparisons. You can also have false negatives due to inadequate power. As I showed you, one basket is really small. So this basket is not really powered for you to actually detect any differences. So there is a problem with spurious associations in subgroup analysis. So the problems are relative effects will be similar across subgroups, and testing for a large number of subgroups can cause spurious findings. So if at all you find a difference, the burden of proof to prove that difference is actually on your side. Okay, so now that you have found some differences in the subgroup, you must actually judge and see, is that subgroup difference, is it credible or not? Okay, so how to distinguish credible from spurious subgroup claims? The next thing that you have to look at is the effect modification based on comparisons between studies, or is it within study comparison? And the third question to ask is, can chance explain the difference in the effect between subgroups? So to answer these questions, there is an EC tool which is available online. It's called the Iceman tool, which is the instrument for assessing the credibility of effect modification analysis. So if you look at it, the authors, they have developed this tool for two different scenarios. They have developed the tool for RCTs. They have also developed the tool for meta-analysis. For RCTs, you have 5 questions. And for meta-analysis, you have about 8 questions. So to understand this tool and to apply it, let's go through a case scenario. So you have Mr. M, who's a 70-year-old diabetic and hypertensive, who presents to the hospital with history of fever and productive cough with yellow sputum for 3 days. And he has developed breathlessness for 1 day. The relatives have noticed that he has become drowsy. So what does this patient have?
1.
He's got a pneumonia. He's come with some fever, cough, and breathing breathlessness. Now, if you on examination, you find that he's oriented only to a person. His heart rate is 120 beats per minute, blood pressure is 100/60, respiratory rate is 34, and his saturation is 86. So this man looks about quite sick, no? He's quite tachypneic, he's hypoxic, and he's confused. So obviously in a curve 65 score, he goes above 2. So now you have diagnosed him with a community-acquired pneumonia. When you're writing the orders in the order sheet, suddenly you have a doubt. Should you add hydrocortisone for this patient or not? So would you add hydrocortisone for this patient with severe community-acquired pneumonia? Okay, so let's look at the evidence for it. So there is this review which looked at corticosteroids and community-acquired bacterial pneumonia. This was published in 2023. So the population was adult patients more than 18 years of age who are hospitalized with a probable or a suspected community-acquired pneumonia. So they used clinical, microbiological or radiological criteria for bacterial pneumonia. The intervention they looked at was steroids with the standard of care, and the control was the standard of care. The outcomes they looked at were mortality, the need for invasive mechanical ventilation, secondary infections, GI bleeding, ICU admissions, hyperglycemia, and duration of ICU and hospital stay. And the time for the study was done in over 90 days. Now, suppose you were the reviewers, what a priori hypothesis would you plan? Okay, age then? Okay, so severity of the pneumonia. Okay, anything else? Sorry? Okay, based on the organisms. Okay, then? Okay, comorbidities. What else? Okay, let's look at 2. So severity of the pneumonia. What do you think? Do you think the steroids will be more beneficial in severe pneumonia or less severe pneumonia? Okay, so you think that there may be a difference. What would you do? Would you combine the subgroups and provide a hypothesis, or would you test them separately? Would you test severe pneumonia? Would you test non-severe pneumonia? How would you go about it? Sorry? Okay, so you would evaluate all the results and then you would provide hypothesis and test it. Would anyone want to go the other way? Okay, so Anna wants to test them both individually. So let's see what the authors have done. So to look at whether they have done an a priori hypothesis, the first step is to actually look at the protocol. So they have registered their study in the Open Science Framework and they have uploaded this in 2022. So if you look at the protocol, these were the subgroups they have planned. One is, like as Amrita said, they looked at the severe community-acquired pneumonia versus non-severe community-acquired pneumonia. And just like you said, they have given the same hypothesis that patients with severe disease would benefit more from corticosteroids. The second thing they looked at were high risk of bias studies versus low risk of bias studies. The third thing they looked at were the corticosteroid types, whether dexamethasone, hydrocortisone, methylprednisolone, was there any difference? They felt that there was no difference among these subgroups. And they also looked at the duration of therapy, whether giving less than 7 days steroids or more than 7 days steroids would have any benefit. They felt that patients who got more steroids, more duration would benefit from the study. And they also looked at the dose response. Now, last time when we were assessing imprecision, we were looking at whether you will use a null hypothesis or do an MID. What would you do? You want to look at a benefit, or you want to see whether that benefit is important or not? Sorry? So you want to use MID. What MID would you use for mortality? How much of decrease in mortality do you think is important? Okay, Ebecha is saying 5%. Any other numbers? Okay, so let's see what the authors have done. So the interesting thing is the authors have gone with Anna's approach. So what they have done is, they feel that there is definitely a difference between severe pneumonia and less severe pneumonia. So they have decided to put 2 different PICOs and 2 different subgroups in the beginning itself. Now, they have also decided to use MID. But the only thing is, they have not told us what MID they're using in their protocol. So actually, this should have been defined before they have done the study and not after they have done the study. And after they have done the study, for mortality, they have chosen an MID of how much? 1%. So that absolute risk reduction of 1% mortality, they felt it was very important. Okay. And for the other outcomes, they have taken 2% MID. For the days, that is duration of hospitalization, ICU stay, ventilator-free days, they have chosen a 1 day as MID. Now, if you look at, they had a lot of studies, and among each of the studies, they have actually divided the studies whether they were severe or non-severe based on the average of the 4th PSI score. If the port PSI score, patients were 4 or 5, more than 50% of the patients had such a high score. Those studies were told as severe studies. The ones which had the port PSI of like 1 to 3 were classified as less severe studies. Patients who went to ICU were also classified as more severe. So you can see actually there is some heterogeneity in the way you actually classify your studies based on your severity. And you can see that each of the studies gave a variety of cocktail of regimens. Some have given prednisolone, some have given methylprednisolone. Yeah. And if you actually look at their overall results, how many analysis have they done? They have done more than 36. Okay, so let's look at the results. So they have, for the mortality versus severity, they have looked at the less severe studies. So we have about 7 less severe studies. And overall, they found that there was no change in your mortality. Okay, so the risk ratio is 1.08, confidence interval is 0.83 to 1.42. When you looked at your more severe studies, they found there was a mortality benefit. Okay, they found that the steroids actually reduce your mortality by 0.62 with a confidence interval of 0.45 to 0.85. Do you think this is inconsistent or consistent? Sorry? Consistent. Most of the confidence intervals are all overlapping. And you can also look at your I-square, which is only 20% over here. If you want to look at the Q score also, you have a Q, you have 12 studies. So your degrees of freedom is 11. You have a Q score of 12.4. So for that, you would actually require a chi-square of 28. This is only 12. So obviously there is no heterogeneity in this particular study. But when you look at the overall, that is when you compare your less severe and your more severe, you find out that when you combine, you have an overall reduction of mortality of 0.75. That is 0.59 to 0.97. But here among the groups, you find there's a definite difference. So if you look at the test for group differences, you have now 2 groups. You have a severe group, you have a non-severe group. So the degree of freedom becomes how much? 1. So for the chi-square for 1 with 0.05 alpha error is 3.84. This study's chi-square is how much? 6.85. And is that significant or not? Yes, it's significant. So there is definite subgroup difference in terms of mortality. So now that you have found a subgroup difference, now it's your job to actually prove that this is a credible subgroup difference and this is not due to chance. So what will we do next? We'll use the Iceman tool. So if you go to Google and type iceman.com, you'll come across these 3 documents. You'll come across Iceman for RCTs, Iceman for meta-analysis, and manual, how to actually use the Iceman. So we click on the meta-analysis document. It also tells us how to go about this. So what they say is complete a separate credibility assessment for each effect modifier. So for right now, we're going to study on mortality versus severity. You must not apply the Iceman if your p-value is 0.1 or larger. How much was our I-square? 0.01. So we can apply this tool. Okay, so the next thing to understand is there are 2 kinds of effects. So basically each question has 4 options. The options on the left means there's definitely reduced credibility. This option means probably reduced credibility. That side is probably increased credibility. And on that side is definitely increased credibility. So you actually want all your results to actually fall on this side, on the right side and not on the left side. So before we proceed, what are we considering? We're going to look at severity versus mortality. So now the next question is, was the effect modifier measured before or at randomization? What do you think the answer to this is? They have looked at severity. Did they decide upon this before the studies were randomized? No, the RCTs have already been done. And now we are looking at mortality. So no. But then if you look at the Iceman handbook, this does not invalidate the analysis because you're looking at between study comparisons. So we can proceed. The next thing is they've asked state a single outcome and the time point. So we're going to follow up mortality for 90 days. And they have asked you state a single effect measure. We're looking at relative risk. So now the first question is the analysis of effect modification based on comparison within rather than between trials? So actually they give more weightage if the studies were done within the particular trial than when comparing the subgroups between various different trials. So in our studies, they have actually looked at between study variability. That means they're looking across all the different studies. They have also mentioned that if a study, in the study itself, in the RCT itself, they have given a subgroup analysis, they have considered that. So over here, I marked it as unclear because they have done mostly between study trials. The next is for within trial comparisons, is the effect modification similar from trial to trial? Because they have not provided the data for the within trial comparisons, I have put it as unclear. So I have given probable reduced credibility for these two questions. Now the next question is for between trial comparisons, is the number of trials large? So you saw that the smaller subgroup, that is the one with the less severe, there were 7 studies, which is still more than above 5. So I would say this is rather large and I will rate it up for credibility. The next question is, was the direction of effect modification correctly hypothesized a priori? So definitely yes, they have told severe disease will benefit from steroids. So I have given it definitely increased credibility. The next question is, does a test for interaction suggest that chance is an unlikely explanation of the apparent effect modification? So here you have to look at the p-value. Our p-value was 0.01. So I gave that as probable increased credibility. The next question is, did the authors test only a small number of effect modifiers or consider the number in the statistical analysis? So here, though they've done 39 analysis, the overall number of effects they have looked at were 6. So I have put it as probably reduced credibility. So then the 7th question is, did the authors use a random effects model? So our authors have definitely used a random effects model. So is the effect modifier a continuous variable? Our effect modifier is not a continuous variable. Ours is a binomial variable. So it's not applicable. So now, no, it is better to use a binomial model because this Iceman tool is not really developed for you to use continuous outcomes. So that's one limitation of this Iceman tool. So overall, I gave it a moderate credibility based on this scoring system. Okay, because we had one definite low credibility and 2 probable low credibility. So now the other important thing is when you present your data, how do you present your data? So if you notice over here, they have split the data for mortality and presented each of them separately, and they have rated for each of them, they have done a certainty of evidence rating. So if you have more severe pneumonia, your relative risk reduces by 0.62, and this is a moderate certainty of rating. Why do they label this as moderate? Is they have downgraded for heterogeneity because of the way you have described the severity. Do you think the study is imprecise or not? Okay, we'll come to that. What about the next line? That is in the less severe pneumonia, the relative risk is 0.108 and your confidence interval is 0.83 to 1.42. You have a low certainty of evidence. Do you think this is imprecise or not? So I'll explain this to you. What did we take actually? We were supposed to compare it to MID. Now the problem is MID is an absolute effect. You're looking at 1% decrease in mortality, but you're assessing inconsistency in what data? You're looking at relative risk and assessing inconsistency. So it's very important that you have to convert your MID into a relative risk. Okay, so how do we do that? So to calculate, so now, okay, just look at this. So you have mortality which is more severe, you have mortality which is less severe. What's the baseline risk in each of them? If you look at the previous study, in the placebo group, what was the risk? 146 out of 1,000 individuals. That means your baseline risk of developing mortality, baseline risk of mortality was 14.6 in your severe group, and in the non-severe group is 7.5. So that's how you got these numbers. The next thing, formula for relative risk reduction. How do you convert the MID to a relative risk reduction? The formula is your absolute MID divided by the baseline risk. So for the more severe pneumonia, it's 1 divided by 14.6, which is 0.068. For the less severe pneumonia, it is 1 divided by 7.5, which is 0.125. Now your next thing is, now that you've got an absolute risk reduction, you have to convert that into a relative effect for MID. So for that, you have to do 1 minus relative risk reduction. So you actually, your final confidence interval ratio, so the MID threshold for severe pneumonia is how much now? 0.932. And for less severe pneumonia is 0.875. Did you understand this? Okay. So basically, what we have done is, we have converted the MID, which is absolute, to an MID threshold, which is relative. Okay, so let's just check all the calculations. So the final MID threshold is how much for severe pneumonia? 0.93. And for less severe pneumonia, it's 0.875. So now go back and look at the results. The MID for the first was 0.932. You can see that the confidence interval is lying at 0.45 to 0.85, which is less than your threshold. So will you downgrade for imprecision? You will not downgrade for imprecision. What about your second? Here you can see that the MID threshold is 0.875, but your relative risk is actually lying below that 0.83 to 1.42. So you will downgrade this for imprecision. That is why here you found that they have downgraded for imprecision and have got a lower certainty of evidence. So did you understand? So here we found that there was inconsistency. So we have done two subgroups. We got the result for the subgroup, and you must also apply different grading for each of the subgroups and how to downgrade it based on the imprecision, based on the MIDs. Okay. So the other, just for the interest sake, we also found out that the rate of invasive mechanical ventilation came down by giving steroids. The ICU admission rate also was down by steroids. The duration of hospitalization decreased by 2.31 by giving steroids. Duration of ICU stay also decreased by giving steroids. So overall, it seems that steroids have actually shown beneficial outcome in patients with severe pneumonia. So this is basically the legend for their certainty of evidence grading. So to summarize, using this example, we have seen a lot of things. We have looked at the importance of planning for an inconsistency, and we have looked at how to identify a priori hypothesis to explain the inconsistency. We have also looked at how to examine inconsistency by looking at a forest plot, visually as well as statistically. And we have also seen that if we have detected an inconsistency, we should check whether your a priori hypothesis explains that. The fourth thing is, if you have a difference, you must actually look for the credibility of that subgroup difference. And you must also provide separate evidence summaries for each subgroup and rate certainty of evidence accordingly. If you find that there is no inconsistency, then you just don't downgrade for inconsistency. So that's the end of our today's talk. Thank you.